Hello everyone, welcome to YouTube live session. Today we are going to talk about the maternal medicine EMQs. The topic we are going to take today is the pregnancy and hypertension, right? So there is a very important guideline. We all know that NICE hypertensive disorders in a pregnancy is a very important guideline for our exam, and basically, the questions do come from this particular guideline very often, and we do get EMQs from this very particular topic. But since there are a lot of things in this guideline, like first we talk about the chronic hypertension, then we talk about gestational hypertension, then we talk about preeclampsia. So there are multiple things in it. So it becomes very confusing often, right? Although in this guideline, you can secure your complete marks in the EMQ, but still, because of the confusion, because so many things are happening here, so we get confused. So here is this session totally dedicated to this particular guideline, and we'll do 15 EMQs from this guideline. And I'm sure this is going to cover all the possible options of the questions we are going to get in exam. So if you have done this much type of questions, I think you are thorough with the guideline. So let's start. And I would really appreciate if you keep answering in the live chat. And definitely that will be helpful because that will also give me an interaction, like what is the confusion, where I can actually correct the confusions. And it's very important that we give the answers, because if you give the answers, I come to know what are the confusing points, where do students can go wrong. And this is how it helps me in the teaching, right? We can always clear the doubts, and it's better to be wrong here than to be wrong in the exam. So here we go with our maternal medicine EMQ session, that is hypertensive disorders in pregnancy. So let me start with our first question, right? So first EMQ is, a woman has been referred to the antenatal clinic at 10 weeks gestation. Low dose aspirin, that is 75 to 150 milligram once daily, could be recommended in the following circumstances. Very important. I know it's very easy that we know that there is one high risk factor. We will directly start the aspirin. And secondly, there are certain moderate risk factors in which at least two factors should be there to start the aspirin. We all have read that list multiple times, but still, we still go wrong with this question. Why? Because then it becomes confusing, right? What was high risk? What was moderate risk? I know there are many charts to remember, so that becomes confusing. But don't worry, we are going to talk about the mnemonic, which will help you in remembering the important points. So first, let's answer what is the correct answer to this question. So maternal age, is it the maternal age? Is it the interpregnancy interval? Or it is the BMI? Or it is the combined, that is maternal age and the BMI both? Previous trimester miscarriages, preeclampsia, what it tells, right? Preeclampsia in the mother or the sister, or preeclampsia in the previous pregnancy. Yes, thank you for answering in the live chat, and I could really appreciate that you all have, many of you have actually given the right answer. So that's the perfect thing. So this the correct answer is, so what is H? What does H says that any woman who has a previous history of preeclampsia is a high risk factor. And whenever there is a high risk factor, even one factor, we are going to start the aspirin, right? So to remember these 5 high risk factors, that is hypertensive disease during a previous pregnancy. So it goes with 1H. That is any type of hypertensive disease in previous pregnancy. Then this second H stands for the chronic hypertension. So if patient is already having a chronic hypertension, then this A stands for your autoimmune diseases, right? So this A stands for immune diseases, and C stands for the chronic kidney disease, and your K. K is for the chronic kidney disease, and C here is for your diabetes, chronic, because it's a chronic disease, right? So hack. Remember hack. If you remember hack, you will not get confused in the exam. So hypertension in the previous pregnancy, chronic hypertension in this pregnancy, autoimmune disorders, chronic diabetes, and the kidney diseases. So this is hack. You just have to remember the hack. Hack is high risk, and we have to start the aspirin from the 12 weeks. Till what time? This is another confusion. Because in exam, they will give you like stop at 36 weeks, stop 24 hours before the delivery, continue till the birth of the baby. So there would be multiple options. So if you haven't fixed your second part also, you may go wrong. But remember, I'm here to correct you. So we'll remember the right thing, that in hack, right? In all the criteria which are there in the hack, we are going to start 75 to 150 milligram of aspirin daily, and we will start from the 12 weeks and go up to the birth of baby. One question with the answer aspirin is definitely going to come, right? So that's how we are going to define this. So now I move on to the second question. 32-year-old woman attends the antenatal clinic at 34 weeks gestation, right? So we'll keep marking what is happening. 32-year-old woman at 34 weeks gestation. Which category she belongs? Chronic hypertension. This is very important that as we read this scenario, we should classify the patient, whether she is chronic hypertensive, whether she is gestational hypertension, or whether she is preeclampsia, right? This is very important because as soon as you classify, you will remember all the picture, the table of that particular thing, right? So now in this patient is specifically about the chronic hypertension. So chronic hypertension secondary to the reflux nephropathy and is known to have mild renal impairment. Her blood pressure is 135 by 90 on oral labetalol with no proteinuria. Fetal growth scans and umbilical artery Doppler are normal. Choose the single most appropriate timing of birth from the above list of options. So the question is now about the timing of birth. When do we time delivery in this patient? Now this patient belongs to the category of chronic hypertension, right? Reflex nephropathy and mild renal impairment does not have any significance for us to decide. This is kind of, you say, additional information or a distractor for you. And 135 by 90. So is the blood pressure controlled? And yes, it is controlled on a single drug. And patient has no proteinuria, so she is not preeclampsia. Her fetal growth scans are normal. Umbilical artery Doppler is normal. So no evidence of SGA is there. Now, patient who is well settled in chronic hypertension on a single drug with labetalol. This is what the question asks about. So if you can make a small question about from your big question, it becomes very easy to directly answer your EMQs, pinpoint the correct answers. Yes. So thank you. Thank you for answering in the live chat. Yes, it is perfect. Like if the patient is on a controlled hypertension, with a single drug, then we can deliver her after 37 weeks. We can continue pregnancy beyond 37 weeks, right? So the correct answer will be after 37 weeks. You might say, when I'm choosing after 37 weeks, why am I not choosing after 38 or after 39? Because that is what the guideline says. We have to follow the guideline step by step, word by word. So these are the two rules from the guideline. Do not offer planned early birth before 37 weeks to the woman with chronic hypertension whose blood pressure is lower than 160 by 110, with or without antihypertensive treatment, unless there are other medical indications. So all other things are normal in this patient. Blood pressure is less than 160 by 110, and it is controlled with the antihypertensive. So a woman with a chronic hypertension whose blood pressure is lower than 160 by 110 after 37 weeks, with or without antihypertensive treatment, timing of birth should be agreed between the woman and the senior obstetrician. So at least she has to cross 37 weeks. After that, the exact timing can be a decision between the obstetrician and the patient. Therefore, I'm choosing the correct option as after 37 weeks. Right? I think there is no confusion. If there are any questions, you can always ask in the live chat. That would be great to do. So now coming to the third EMQ, right? So 40-year-old woman has been referred to the assessment unit at 36 weeks of gestation because of hypertension. Now, patient is at 36 weeks of gestation and she is a case of hypertension. So let's see to which category she belongs. She has a history of chronic hypertension. Great. So let us clearly mention that she is chronic hypertensive. So now we will remember all our chronic hypertension scenarios. And ACE inhibitors were changed to labetalol prior to pregnancy. ACE inhibitors were changed to labetalol prior to pregnancy. This is a perfect thing to do because we need to change the ACE inhibitors to the labetalol. Now, the renal function is normal and the fetal growth scan and the umbilical artery Doppler velocity has been normal. Her BP is 180 by 115 millimeters of mercury with no proteinuria and she is asymptomatic, right? So her blood pressure is 180 by 115. That is, she is severe hypertension above 160, 110, but there is no proteinuria and she is asymptomatic. Now, you have given the oral labetalol, you have given the intravenous labetalol, but still her BP remains high above 170 by 110. Now, what is the most appropriate timing of birth for this particular woman? So, yes, basically here, now this patient fits in the criteria where we have to act early because she is not controlled on her antihypertensive treatment with one drug, right? So she is not getting controlled and she is still in a severe hypertension. So what we need to do now, when we can offer her the birth? Of course, it is prior to 37 weeks and she's already 36 weeks, right? So we have to offer her early birth. So how early we can offer her? Once the BP is adequately controlled. So once her blood pressure is controlled, she can go ahead with the delivery, right? So we are just waiting for the control of blood pressure because that will decrease the risk of maternal morbidity and we can go ahead with the induction, right? So once the BP is adequately controlled is the right answer. So there is, now you can see one is the previous scenario. In second question, we just talked about where the blood pressure was controlled. So in that case, we said we will go beyond 37 weeks. And the another is when the blood pressure is not controlled. And when the blood pressure is not controlled, then what? Then we have to act immediately after controlling the blood pressure. Remember, this is for the hypertension. I'm not talking of preeclampsia. Now coming to EMQ4. Yes. Okay. So you can just leave your questions in the live chat. You are very much welcome to do that. So EMQ4, 32-year-old woman with a history of chronic hypertension has been treated antenatally with the labetalol. Labor is induced at 38 weeks and she had a vaginal delivery. So 32-year-old woman is there. She has a chronic hypertension. Again, we have clearly mentioned that this is a scenario of chronic hypertension and she has been treated antenatally with the labetalol. Labor was induced at 38 weeks and she had a vaginal delivery. Post-delivery, her BP is 150 to 160 and 90 to 95 is the diastolic. Choose the single most appropriate management. So you need to choose the single most appropriate management. So what we need to do for this patient? Of course, yes, because she was on labetalol and already on antihypertensive and still her blood pressure is high. So what would you like to do? Yes, the obvious thing is we are going to continue the antihypertensive therapy. See, there are three options. Continue antihypertensive therapy, oral labetalol, and consider reducing antihypertensive therapy. So basically, first thing is we have to continue, right? When we reduce or when we stop, we reduce when it is less than 130 by 85 and we stop when it is below 110 by 170. So we are not going to do that. We are just going to continue the antihypertensive therapy. Monitoring, like mentioning about monitoring how many times or that is also important. But right now, first thing is to do is give her antihypertensive, and then we will monitor her, right? So the first and the foremost important thing to do is that we have to continue her antihypertensive, right? So this is the one thing which you are going to do. So I is the correct answer. So I option is continue antihypertensive therapy. Now, in women with the gestational hypertension, this is about the gestational hypertension. We do continue that in the postnatal period. Okay, but in chronic hypertension also we'll go back to her. We will go back to her previous antihypertensive, right? Now, why we not shifting on to oral nifedipine? Because actually labetalol is good enough. If she was settled on that, we can continue using that. But if you have to start the new one, then you may prefer the nifedipine. But right now, at this point of time, because she's already settled on the labetalol, so we can continue that. But we have to take care. If the patient is on methyl dopa, she is on a controlled hypertension with the methyl dopa, then that we cannot continue in the postnatal period because of the risk of postpartum depression. So in that case, we need to stop that and shift on to the other antihypertensives. Okay. So yes, this is about the monitoring. We'll come to this particular thing as we move further. So basically what we are doing, measure the BP daily for the 2 days after birth, at least once between the day 3 and day 5 after birth, as clinically indicated if antihypertensive treatment is changed after birth. Blood pressure should be, keep the blood pressure lower than 140/90. So as you saw here, the blood pressure was more. So we continued on taking the antihypertensive. Continue antihypertensive treatment, offer a review after 2 weeks after the birth with their GP or specialist so that if they have to change the antihypertensive or if the control is not good, then they can modify the treatment. If patient is on a methyl dopa, I already told you that we have to stop that drug because there is a risk of postpartum depression. And there is one review at 2 weeks with the GP or specialist, and the next review will be at 6 to 8 weeks. This is also an important exam point, right? So first review is at 2 weeks, and then next review is at 6 to 8 weeks after the birth with the GP or specialist. Yes. So here we go with the fifth question. A healthy 32-year-old woman attends the assessment unit at 36 weeks gestation because of hypertension. Her blood pressure is 140 to 145 and 92 to 95, and there is no proteinuria and an automated reagent strip testing. She has no symptoms. Choose the single most appropriate management. Now, what is the scenario here? Because she is detected for the first time at 36 weeks, then what happens? Then it is the gestational hypertension, right? So this is gestational hypertension, and this is in the range of 140 to 145 and 90 to 95. Then it is basically mild to moderate, right? So it is mild to moderate gestational hypertension. So choose the single most appropriate management. What we do for mild to moderate hypertension? Yes, correct. So basically, we are going to do the preeclampsia blood, and we are going to give her oral labetalol as outpatient, and we are starting the BP monitoring, that is 1 to 2 times a week. So G is the correct answer. Preeclampsia, blood test, oral labetalol as outpatient, and blood pressure 1 to 2 times a week. This is a correct answer, right? We are going to do all the blood tests for her, preeclampsia blood test. We are going to give her oral labetalol, and blood pressure should be monitored 1 to 2 times a week. That is the correct answer for mild to moderate hypertension in this particular patient, right? At 36 weeks, we will not think about the delivery because it's mild to moderate hypertension, and if it gets controlled in the labetalol, we can go beyond the 37 weeks, right? So therefore, G is the correct answer. Okay. Moving on to the next question, that is EMQ 6. Now, 42-year-old woman attends the assessment unit at 30 weeks gestation because of hypertension. Her blood pressure is 144 by 94 and there is no proteinuria. Blood pressure is 144 by 94 and there is no proteinuria. She has no symptoms and there are good fetal movements. So again, what is this scenario? This is again mild to moderate gestational hypertension. Now we'll just remember that chart which is given in the NICE guideline with the one column for mild to moderate hypertension and the other column for the severe hypertension, right? So we're just going to follow that. Now, in the previous question, it was asked about the maternal monitoring. In this question, they are asking about the fetal monitoring. So what do we need for the fetal scans, right? So in fetal scans, we need to do the growth scan right at this point of time and the umbilical artery Doppler at this point, and then we will repeat it after every 2 to 4 weeks. So what is the correct answer? It is the correct answer, right? So growth scan, and you do the umbilical artery Doppler at diagnosis, and every 2 to 4 weeks, you will do this, right? So that's it. So this is the correct answer. Which is the correct answer? Yes, very good. Yeah, please keep answering in the live chat and please keep putting your questions in the live chat as well. We'll certainly take up your questions, right? So coming to EMQ 7. So here, 32-year-old woman with the gestational hypertension has a spontaneous vaginal delivery following induction of labor at 38 weeks gestation. 32-year-old woman with the gestational hypertension. Again, you see the scenario is clearly of a gestational hypertension. And she has a spontaneous vaginal delivery following induction of labor at 38 weeks gestation. She was treated with oral labetalol in the antenatal period. 48 hours after delivery, her blood pressure is 110 by 60, right? Now, in this question we are talking about, she was a case of gestational hypertension and she was on oral labetalol. We had a similar station in our past slides as well. But in that case, after delivery, her blood pressure was still high, right? Here the blood pressure is 110 by 60, right? So now what to do? She is 110 by 60. So we need to, do we need to continue the antihypertensive? Yes, you guys are right. We don't need to continue. So what is the next thing we have to do? If we have to monitor the blood pressure. So where to start the monitoring? The first step of starting the monitoring is monitor the blood pressure daily for first 2 days, right? So first 2 days we monitor daily and then we monitor between 3 to 5 days, right? So this is what rule we are going to follow here. So monitor the blood pressure for the first 2 days. That's the correct answer. So in women with gestational hypertension who have given birth, measure the blood pressure daily for first 2 days after birth, at least once between 3 and day 5 after birth, as clinically indicated if you are changing any antihypertensive treatment, right? So therefore, we are going to choose here daily for first 2 days after birth. Great. I hope everything is fine. Thank you for answering in the live chat. That makes the session quite interactive. So here we talk about the EMQ 8. A community midwife. Now remember, see where the patient is. She is in a community, right? Because again, that will make a difference in your EMQs. These small differences actually make your answers wrong in the exam. If we do not pay concentration on these small things, then we may choose, like if the patient's blood pressure is rising, we may choose oral labetalol, right? But remember, this is what the midwife has seen, okay? So our next step will be slightly different. Let's see what this question says. A community midwife seeks your advice regarding a 32-year-old primigravida at 34 weeks. Okay? The woman had no additional risk factors at booking and her BP was 90 by 60 millimeters of mercury. The midwife is concerned about the woman's blood pressure and that is 144 by 95. So now they have given you the previously her blood pressure used to be 90 by 60, which was absolutely normal. But at this point of time, when she is now 34 weeks, her blood pressure is 144 by 95, and there is no proteinuria. So what is happening? Can we diagnose this as a case of mild to moderate gestational hypertension? Mm-hmm. Yes, no, yes, no, no. We cannot go with the gestational hypertension at this point of time. Right? We cannot go for that because this is only one reading which is there in the community, right? Which is there in the community midwife. So what to do? Now this reading needs to be confirmed. But can she go home? Can she just stay and sleep? And what to do? No. She has to attend the obstetric unit for assessment, right? So she has to attend the obstetric unit for assessment. So midwife will refer that patient to the obstetric unit so that she can be assessed, and according to her assessment, we can, if she requires, we can put her on the treatment or what next things we need to do. But remember, that's the difference. If this patient is in the urgent unit or already she is in the obstetric unit, then we may think starting the oral labetalol. But here, because she is in the community, so we will not directly jump on to. So you may actually think like if there is an option of starting labetalol and then preeclampsia blood checks and monitoring the BP further, as we had a previous one question. But in this, because of the community midwife, first we need to check in the obstetric unit for assessment. So C is correct answer here. Okay, great. EMQ 9. A healthy 22-year-old woman has been referred to the assessment unit at 28 weeks gestation. Her blood pressure is 165 by 110 and there is no proteinuria. She is asymptomatic and there are good fetal movements, and choose the single most appropriate management. Again, first, as I always say, we will classify this patient. To which category she belongs? She is severe pregnancy-induced hypertension, right? Severe gestational hypertension. Now remember your chart of severe hypertension. Then what to do? Fetal monitoring is largely same, right? Fetal monitoring is largely same. So because the fetal monitoring is largely same, so what it is, basically, what we need to do is that we will go ahead with the preeclampsia blood test and admit and oral labetalol. Are we going to do this? Yes, because she is severe hypertension. She is severe hypertension. So we will first admit her, right? Admit the patient and then do the preeclampsia blood test and oral labetalol. So admit the patient, give the preeclampsia blood test and oral labetalol. That's the thing. Of course, this is severe hypertension, right? So why we are doing, we are admitting her but still giving oral labetalol? Does this question comes to your mind? Yes, that's a very genuine question, but that's the correct answer, right? We start with the oral labetalol first in cases of hypertension. I'm not talking of preeclampsia, right? This is severe hypertension. So we start with the oral labetalol. If it does not work, then we move on to IV labetalol, right? So therefore, K is the right answer. That is the preeclampsia, blood test, and admit and oral labetalol. Now coming to the next question, that is 40-year-old woman has been admitted at 34 weeks gestation because of preeclampsia. 40-year-old woman has been admitted at 34 weeks gestation because of preeclampsia. She has no symptoms and there are good fetal movements. Her BP on admission was 175 by 150 and the urine PCR is 154 milligram per millimole. Treatment with labetalol was started and her BP is now 150 by 95. Preeclampsia blood test, fetal growth scan and umbilical artery Doppler are normal. Now what we need to do in this patient? So basically, yes, What we need to go ahead with that? Okay, so we will continue monitoring this baby with every 2 weekly doctor, right? So we'll continue monitoring this baby every 2 weekly. So what is the correct answer? F is the correct answer. That is growth scan plus umbilical artery Doppler every 2 weeks, right? So growth scan plus umbilical artery Doppler every 2 weeks is the correct answer. Now, coming on to the next question. A healthy 20-year-old woman has been admitted at 31 weeks gestation because of preeclampsia. Healthy 20-year-old woman has been admitted at 31 weeks gestation because of preeclampsia. She has no symptoms and there are good fetal movements. Her blood pressure is 145/92 and there is 3 plus proteinuria. So now this is a case of preeclampsia with a mild to moderate hypertension. So preeclampsia blood tests are normal. CTG growth scan and the umbilical artery Doppler are normal. Choose the single most appropriate strategy for her. So what we need to do now, we are again talking about the fetal monitoring. So again, the same thing. We are going to do the growth scan and umbilical artery Doppler every 2 weeks. You know, the fetal monitoring is easy because we need to remember only this thing, right? So we are checking the growth scan and the umbilical artery Doppler every 2 weeks. Okay, so here is the EMQ 12. A healthy 23-year-old woman has elective cesarean section at 38 weeks because of preeclampsia and breech presentation. Her BP is 130/80 millimeters of mercury 48 hours after the delivery, and she is not on any antihypertensive treatment. So her BP is settled, right? Already 48 hours is gone and she is not on any antihypertensive treatment. So her blood tests are normal. Woman wishes to be discharged. Choose the most appropriate instructions for the monitoring, right? Blood pressure is normal. Now she is going to be discharged. Already 48 hours gone. So now what? Does she need antihypertensive? No. So what next? Next is her BP monitoring once between 3 to 5 days. So community midwife to monitor the blood pressure at least once between 3 to 5 days, right? So H is the correct answer. Community midwife to monitor the blood pressure at least once every 3 to 5 days. That's what we are going to do. At least 4 times a day while the woman is an inpatient, at least once between 3 to 5 days and 1 alternate days if BP was abnormal on day 3 to 5, right? So we are going to take up this 3 and 5 days after birth. Okay, so now coming to EMQ 13. A healthy 38-year-old woman is referred by her community midwife because of hypertension and proteinuria at 38 weeks gestation. Her blood pressure is 145/92 and there is 3 plus proteinuria. She is asymptomatic with good fetal movements and a normal CTG. Blood tests are normal. Choose the most appropriate management. She is 38-year-old woman and she is referred by her community midwife because of her hypertension and proteinuria at 38 weeks gestation. And her blood pressure is 145/92 and 3 plus proteinuria. She is asymptomatic and good fetal movements. What to do for the fetal monitoring, or what is the next management we need to do? So her blood pressure is controlled. She has proteinuria, but she is a case of preeclampsia. So how long we can go ahead with this patient, right? How long we can go ahead with this patient? So what we can do for this is, right at this point of time, we have to now induce because she's already crossed 37 weeks. In preeclampsia, the highest limit is 37 weeks, right? She has already crossed 37 weeks. So what she needs to do is induction of labor within 24 to 48 hours, right? So that is what we are going to do. So F is the correct answer. Now, what are the criteria where we need early birth? So one is inability to control the blood pressure despite using 3 or more classes of antihypertensives. SpO2 is less than 90%. Progressive deterioration in the liver function, renal function, hemolysis or platelet count. Ongoing neurological features such as severe intractable headache, repeated visual scotoma or eclampsia, placental abruption, and reversed end diastolic flow in the umbilical artery Doppler or non-reassuring CTG or stillbirth. So in all these conditions, we need early birth. That is, we have to terminate the pregnancy before 37 weeks. But if it is like controlled, then also in preeclampsia, the highest point where we can go up to is the 37 weeks. And this patient is already 38 weeks, so we can just go ahead with the induction and delivery. Okay, so here we go with the next EMQ. 42-year-old woman attends the antenatal clinic at 12 weeks gestation in her third pregnancy. Her first pregnancy was uncomplicated. Her second pregnancy was complicated by severe preeclampsia at 26 weeks gestation, resulting in delivery by cesarean section at 29 weeks, with birth weight on the 20th centile. Right, so this is her third pregnancy, but in the second pregnancy, that is, she has a previous history of preeclampsia, which was terminated. That pregnancy was terminated quite early, less than 32 weeks, at 29 weeks, right? So very high risk patient. Her current blood pressure is 130 by 88, and there is no proteinuria. She is already taking aspirin. So what is the next thing to do? Now the question largely asks about the monitoring for the baby. So for the baby monitoring, what is the correct answer here? She will require the growth scan and umbilical artery Doppler every 4 weeks from, do we need to start from 24 weeks or the 28 weeks, right? We need to start from the 24 weeks because we will start quite early from the period she delivered, right? So at least 4 weeks prior to that. So if we do have 4 weeks prior to that, we are at 24 weeks. So H is the correct answer here, right? So the thing is, we start the fetal monitoring, that is fetal growth scan and amniotic fluid volume and umbilical artery Doppler at 28 to 30 weeks. But we repeat it 4 weeks later. But at least we should start 2 weeks before previous gestational age of the onset if it is earlier than the 28 weeks, right? So therefore, we need to start it early. Now coming to EMQ 15. A healthy 30-year-old woman has been admitted at a 34 weeks gestation because of preeclampsia. She has no symptoms and there are good fetal movements. Her blood pressure is 157 by 105 and there is 3 plus proteinuria. Preeclampsia blood tests are normal and she is treated with the oral labetalol and labor is induced at 37 weeks. Her blood pressure during labor is 152 by 100. So what do we need to do? The question is about the intrapartum monitoring, right? So for the intrapartum monitoring, the blood pressure has to be monitored hourly. Yes, that's correct. So hourly blood pressure monitoring is the correct answer. So intrapartum care, blood pressure during labor, measure the blood pressure early in women with the hypertension every 15 to 30 minutes until blood pressure is less than 160, 110 in women with severe hypertension, and continue the use of antenatal antihypertensive treatment during labor. So that's about the questions for today. And if you really want to learn in this interesting way, you find this interesting, then you are welcome to join us in our courses, like full course and the crash course. Crash course is definitely for the January people, and full course has unlimited access till you pass. So if you haven't decided yet when to go ahead, still you can go ahead with that. You want to discuss your concerns, your preparation with me, you can scan the QR code and schedule a meeting with me. And let's do MRCOG together in 70% less study time. Thank you so much for joining today in the YouTube live session which we had. And yes, I would definitely like to see if there are any questions. We can definitely take up those. Just a minute. I can just pick up the question from here. Good. So there are actually no questions, but you guys have answered the questions very well. So thank you so much for joining today, and thank you for participating so actively and making it a success. Thank you. Thank you.